Hello and welcome to another edition of the Osteopathic Lyceum podcast. As is evidenced by sort of the arc of things I've been talking about in more recent episodes, I'm going to consider the general concept or the general divide between the biomedical and the biopsychosocial model, probably at maybe a more superficial or more basic level than would be provided if I had very specific papers to compare and contrast. But I'm going to speak sort of off the cuff and from more of an opinion based, not necessarily as evidence informed or evidence based as I often would, but that sort of doesn't matter because again, what we're looking at is the arc of these things. So it's becoming more evident to myself based on the articles that are catching my eye within the osteopathic profession that there is at least some attempt to inculcate the biopsychosocial model as central. There is at least some terms that I've seen or some descriptions that I've seen that call the biopsychosocial model, say, more up to date, the biomedical model being less up to date. Now, osteopathy as a profession and hands-on manual therapy as a broad category of professions are less likely to have a lot of room to truly innovate with their actual technical methods because those technical methods exist in a very well-defined environment external to the patient and have an obvious limit to the amount of technical things that you could do to somebody, despite maybe not wanting to acknowledge that and really tune into that and work on that technical side to really make proficient practitioners. So a possible, say, orchard with low-hanging fruit would be to shift the focus away from the technical skills, the hands-on technical skills, and shift it more towards other types of interventions, other types of concepts and ideas, because there's more room for growth within a profession, quote unquote growth within a profession, outside of its main technical sphere. So in order to convince people that that's of use, you have to make some argument for it. I think in previous editions of this podcast and previous discussions that I've had, essentially as a talking head, I've made a decent case to suggest why I at least am of the position that the biopsychosocial model doesn't do anything for osteopathy. It doesn't do anything for massage. It doesn't do anything for chiropractic. There is evidence that I've discussed that essentially suggests that if you teach people an in-depth communication program or in-depth communication skills explicitly within osteopathic education, it suggests, or the people's feedback is that that is the most important thing they think clinically as novices. Now, the reason that they make the argument in the paper that I talked about in the last episode is that when you ask 8 professionals what they think is the most important with respect to clinical skills, they will say that the technical skills were the most important when they were novices, and the communication skills are the most important as experts. Now, one of the challenges with that is that you're asking people what they think without observing any outcome or performance-based data. You can choose the outcomes or the performances that you prefer, and that will allow for argumentation one way or the other. So if you like the concept of patient satisfaction as a measure, then yeah, the communication skills will likely shine. They'll likely look very good. If the patient information that you're looking for, the outcomes that you're asking patients about are more, did it change your ability to function, then the technical skills are predictably going to shine. It is completely unfair to suggest that how you communicate with a patient is anything other than exceptionally important. How you communicate with a patient is going to allow them to understand what you're finding, what you're doing, why you're doing it. It's also going to allow them to connect with you in an appropriate way that allows them to approach the therapeutic interface that you're going to build together. If you're a dink, if you're a prick, that's going to turn them away. So at minimum, don't be a jerk. But to look at the expert who's saying that communication skills are exceptionally important, that's in the background noise, in the general background noise of those practitioners not necessarily being explicitly taught communication frameworks, that is in the background noise of the normal movement from novice to expert. So I don't know that it has the value that you would want it to have. Attempting to train a novice to be an expert is probably not the most appropriate way to do it. Teaching them explicit frameworks for how to adjust in varying situations within a FAR transfer paradigm probably does a pretty good job. If you really want to know my thoughts on that, you can go ahead and dig back through the library of things that I've said. But in essence, a FAR transfer paradigm or FAR transfer is going to be predicated on things that are non-tangible, non-visible, right? So they can't be seen, they can't be touched, but they're sort of always there. They're frameworks that, while abstract, are also consistently present. And from those, you can teach explicitly to them. So you teach exactly what those frameworks are, and you teach the variety of ways that they may present themselves. So you teach people how to leverage them. That, I think, has a lot of value. You can prime for FAR transfer, especially in environments that are likely to be highly variable and uncertain, such as any form of clinical practice. So the biopsychosocial model as an educational tool will do nothing for that. A biopsychosocial model communication format might have that. I can't evaluate it because I haven't seen it. But the actual technical hands-on skills are the interface that the practitioner meaningfully has. That is the skill set. So what this allows me to do, just that point, allows me to consider something that I have heard many times. Now, this is where it's constructivist, because what I'm about to say does depend on me. It does depend on my previous experience. It does depend on my environment of observation, especially at this particular time. So I have to admit that up front. But in saying that, one of the classical critiques, if you use the term biomedical versus biopsychosocial, is that the medical profession or the allopathic profession or physicians or medical doctors, that they are exceptionally bad at chronic care, they are only good at emergency care, and they come out of a battlefield paradigm. So they were essentially emergency medicine. They'll save your life, but they can't do much else. Now, there's some degree of fairness to that, but if you use the term allopathic medicine or you use the term physician, you're sort of creating this straw man fallacy or this really weird nondescript construct of physician. Well, if you know much about the medical profession, there's a huge amount of subspecialties. And essentially each physician is unique in that they subspecialize not only within quote unquote a specialty, but with particular intervention methods. So not all orthopedic surgeons do the same orthopedic surgery. Right? Not all gastroenterologists use the same technology. They don't all use the same scopes. There's a variety of things that are happening here. So there is still a lot of bespoke elements. So if you use the concept of physician as a construct, or as a box, or as an abstraction to describe a general profession and why they don't do the things that you like, you're ignoring the wide variety. And they all have very, very unique, interesting skills, some of which don't include appropriate communication depending on the particular physician, some of which do, just depends on the particular physician. As with any group, they're highly variable within the group, but they have very obvious, unique skill sets that are exceptionally important in the right circumstance. So my general argument there would be, let the profession wield its most useful skill set. Don't have the expectation that any physician, that any chiropractor, that any osteopathic practitioner, that any massage therapist, that any physiotherapist, that any psychologist, that any healthcare practitioner of any form, any naturopathic doctor, has to be everything. Don't have the expectation that somebody should be an expert communicator because they're a healthcare practitioner. Expect that they have a skill set that can benefit the right person in the right situation and leverage that. So sometimes it is highly valuable to be highly reductionist and focus on particular things. So I'm not necessarily saying stream down and turn everything into a niche. I'm saying that the actual strong skill set of a profession is probably the thing that is most valuable to shine. So in osteopathic manual therapy, it's obviously a hands-on methodology. It obviously has one thing that really differentiates it from other hands-on professions, and that's the barrier concept. when applied appropriately, it means it automatically must be patient-centered care because you have to respond immediately and appropriately to how the patient is responding to the interface between the practitioner and the patient. It is between them. There are going to be critiques that essentially suggest that osteopathy is done to patients by practitioners. And if the barrier concept is appropriately centered, that's not how it actually works. It's not how osteopathy is necessarily fundamentally built to function. It's fundamentally built to function very much in response to how the patient responds in that moment. There's a lot of subdivision that has happened across time within the profession of osteopathy that actually makes that harder, such as the things that I talk about a lot: cranial and visceral, and strain counter strain, and facilitated positional release, and both direct and indirect myofascial release, and muscle energy. There's all these subdivided things that were really probably more than anything else communication frameworks to show people learning how the person who was doing it would describe it so that you could do the same moves. But if you do anything other than center the barrier concept, even within those, then you're not doing, okay, this is inappropriate, it's not fair, but I could make the claim that you're not doing osteopathy, quote unquote, but that's not even fair. I think what is more fair to say is that the subdivision of concepts in order to transmit from expert to novice how to do certain things has a normal challenge that the expert is unaware of how to properly communicate the thing they actually do. It's a normal problem of experts. They can do, but they can't explain often. They can't necessarily explain how they got from the novice position to the position of doing what they actually do. So they make these models and these frameworks, and they have flaws in them that are not properly communicated. So through a normal process, osteopathy has these weird subdivided systems that don't properly center the barrier concept. And then people glom onto those or grab onto those instead of grabbing onto the central thing. Now, as much as I'm somebody who has rough words for what I would call the philosophy of osteopathy, or the approach of osteopathy, to call itself a philosophy and not necessarily a biomedical approach or a hands-on approach, is that philosophy is thinking without the requirement of evidence that allows you to come to appropriate conclusions. I'm not a fan of that. And even in saying that, I am centering one of the central philosophical concepts that wasn't properly described at the initial portion of the profession in the barrier concept. Those words came later, but the concept of don't hurt the patient was definitely there. So early writings do definitely talk about securing relaxation, about relaxing the articulation at both ends. Don't hurt the patient, don't hurt the patient, don't hurt the patient. That's definitely there. And then it coalesces into what we can now term the barrier concept. And the way that I try to communicate the barrier concept is don't make them say ouch. All right. So then that breaks down into a more subdivided choice matrix, which doesn't matter right now. But what does matter is the attempt to inject the biopsychosocial model into the osteopathic profession probably makes a lot of assumptions. One, that the biopsychosocial model has particular value with respect to clinical practice, which I don't know that it absolutely does. Some people will argue for it. I get it. But it also comes out of a biomedical model, right? It is essentially the response to seeing patients who may not have been getting as ideal a range of results as possible by a gastroenterologist, because that particular gastroenterologist got really interested in psychological and social factors as determinants of health. Psychological and social factors are large determinants of health, but they are not necessarily leverage points for a manual hands-on practitioner. There are leverage points for other types of professionals who have very strong skill sets in those things, such as psychological professions, be it psychiatry, psychology, whatever we want to talk about. Those professions have those skill sets. Osteopathic practitioners, massage therapists, physiotherapists, chiropractors, traditional Chinese medicine practitioners, maybe, but maybe less so. Naturopathic doctors do to some degree because they actually are trained with some psychological intervention or at least counseling. But, a massage therapist, chiro, and osteophysio, the leverage point is not psychology. It is not sociology. You are in a psychological and social context, which is why my simplest suggestion would be don't be a prick to your patients. Don't make yourself unapproachable. But It's not what you do. It's not your strong skill set. So to critique the biomedical model for not considering psychology and social circumstances as much denies the strong skill set of your classical medical professional, being your physician, such as your gastroenterologist, your orthopod, your internist, your emergency physician, your your thoracic surgeon, or your cardiologist. Those people have very strong skill sets. They subdivide so that they can be good at something and save lives. Critiquing the biomedical model for that is denying the strong skill set. It's also putting this really interesting concept on people, asking them to be everything to everybody. I don't necessarily need a cardiac surgeon or a cardiologist to be good at helping my feelings. I need them to be good at diagnosing what is going on with my heart and suggesting appropriate interventions that will actually work for me. So if you try to pull somebody away from really going after their strongest central skill set, then you're going to lose some of that or the possible growth there, even if it's only minuscule. So again, my general suggestion is that the attempt to inject the biopsychosocial model into osteopathy is a possible area for low-hanging fruit for growth within the profession and change within the profession, but it may not be the appropriate change. It may not be the appropriate growth. What I would say is that one of the banes of osteopathy's existence is its claims, not its work. We haven't focused enough, in what I can tell based on the reading that I've done, we haven't focused enough on the technical side, on what things actually do. My claim is osteopathy is bad at science. Therefore, they have not set up appropriate experimentation or appropriate observation to identify what osteopathic practitioners consistently do and how they can leverage it and wield it. They make claims such as, I can palpate cerebrospinous fluid. And when you go investigate that, the answer is no, you can't. If you can, there's major problems. I can palpate the movement of the liver. No, you can't. If you can, there's major problems. So major emergency medical problems. Let me clarify that. So if you set up your experiments, if you set up your claims, and you keep getting this bad feedback from the scientific method, then, well, okay, maybe osteopathy doesn't work by hands-on methods. Maybe osteopathy works because of the patient-practitioner dyad or the patient-practitioner relationship. There's definitely powerful stuff there. I cannot deny that. There's definitely powerful stuff there. But if you don't have the strong technical skill set as a novice to improve as an expert, then you can't take on the value of the communication because you suck. You're a bad practitioner. You don't get results. So of course you think the communication is the most important thing, and that's what you're going to tell everybody. It's like, oh, it's not about what you do with your hands. It doesn't matter what you do with your hands. The results are all over the place. I really do believe that there are ways to appropriately investigate the fundamental methods, how often they work, what ranges they work in. One of the things that I'm doing to attempt to investigate that is the students at the Osteopathic Lyceum are doing thesis-based experiments, or experiment-based thesis. Let me say that properly. They're doing experiment-based theses, or thesi. My Greek is not the best, in order to investigate some very fundamental technical stuff. How often does a leg rotation impact the range of motion of the opposite shoulder? How often does treating one end of a theoretical chain or a hypothetical chain affect the other end of the chain? What are the conditions under which it does that? What are the conditions under which it doesn't do that? To start to investigate that so that we actually have some range of understanding of the predisposing factors to particular methods actually doing something. And we'll start with things like range of motion. Does it actually change range of motion in an observable and consistent way? If it doesn't, then sort of full stop, right? Maybe it isn't a physical thing. Maybe it is much more of a relationship thing. But if it does, we need to know that. How often does this thing do, this method, whatever method you choose, do something to heart rate and respiration? If it doesn't, well, full stop. But if it does, and I've already discussed that at least with respect to some of the students who are producing data so far at the Osteopathic Lyceum, there is some signal that something happens. But we want to know, is that better than, say, a pharmaceutical intervention, right? Maybe for changing blood pressure and heart rate, the best intervention isn't pharmaceuticals and it isn't osteopathy. Maybe it's just being in decent physical health, such as having acceptable levels of cardiovascular health. So you're very good at managing your cardiovascular system through exercise, something like that. That might actually be the most powerful intervention. So if somebody's having blood pressure problems, or you think there's something wrong with their nervous system, their autonomic system, is the most appropriate thing osteopathic treatment, or is the most appropriate thing consistent exercise? That's a valuable question. So instead of instead of trying to inject a model that probably doesn't appropriately respect the central skill set of a profession, such as osteopathy. So instead of trying to inject the biopsychosocial model, because we've had a lot of failures on the biomedical side as far as our claims, maybe we just need to get more fundamental, more basic, and investigate that stuff. And then we'll have some more information to figure out if we should consider the biopsychosocial model, or if the biopsychosocial model is the most appropriate one to look at. Because I wouldn't argue that it is. I would argue that the biopsychosocial model has very little value to the osteopathic profession. I've said this many times, so just reiterating it. I think one of the things that would benefit the profession is to get way back to the fundamentals, instead of going to all the complicated stuff where we seem to have challenges. Some of the research is getting a little bit better, a little bit more accurate, a little bit sharper, but I don't know that it is the thing that it wants to be. So once again, my general argument is let's get the fundamentals right and stop making assumptions multiple layers up. Let's get back to actually investigating what the heck is happening in the profession, and maybe consider from the biomedical side and do a better job of that. Don't start from, I know I'm correct, this is what's happening, and then finding out that you're wrong, because that'll hurt your feelings. And then you'll only want to talk, well, that's not fair. Maybe I'm being superficial and saying then you only want to talk about feelings, but whatever. That's inappropriate. That's incorrect. Maybe it's more appropriate to do the very fundamental research and then figure out if there's anything there, if there's any mileage, if there's any leverage there. If there is, let's work with it. Don't just jump over multiple layers up with a lot of assumptions to a model that really isn't what people think it is from the words. So high degrees of technical skill, let professions really focus on their actual area of skill so that they can really benefit people with that skill set, whether it's a physician of whatever subspecialty, whether it's a naturopathic doctor, whether it's a chiropractor, doesn't matter. Let people actually express their skill set and do a better job with the fundamentals. Stay away from the wacky stories and the wacky claims. Maybe let's get back to work on the fundamentals. So hopefully some of that was of value to you, and I look forward to talking to you again soon.